We are here to try to learn more about epilepsy and how does it work with Dr. Nilesh Kurvale, which is one of the few doctors in India that specialize in epilepsy only. So thank you for being here.
Thank you, Leo. Thank you.
And thank you also for letting me have these 2-3 weeks of internship with you, in which I had learned so many things. And I've also made some questions, in order to actually understand what is epilepsy.
Oh yeah, great.
Starting from the very basics to even some more specific ones. So, if it's okay with you, we can start with a very, very basic question for
Yeah, sure, yes. Please go ahead.
This is for actually anyone. I met a taxi rider and he asked me, "What are you doing?" And I was like, "I'm in the epilepsy department." And so his question was, "Oh, what is epilepsy?"
Yeah. So see, for all conventional terms, epilepsy is a seizure or a convulsion. Typically, we call it involuntary movements of your hand or a body and legs with loss of consciousness to the surrounding, and side by side you can have urination, tongue bite, salivation. Those are kind of autonomic symptoms, what we call it. So it's you lose the touch with the reality with a lot of involuntary thrashing movements of your body. Okay, so that is what we call a convulsion. And if you repeatedly keep getting these convulsions, your diagnosis is epilepsy. So we call it a epilepsy disorder.
Okay. So convulsions and seizures are synonyms.
Yes, for common people, I would keep the medical jargon out of it. Okay. But yes, more or less same. But convulsions is typically when you have a convulsing movements. It comes from the English word, convulsing movements of the body parts. But seizure can be anything. You can have, there are a lot of types of seizures where you can simply stare at someone, spit at someone, behave little awkwardly with the loss of your consciousness or loss of touch to the surrounding. So that typically is called seizure. Convulsion is the word kept for when you have a involuntary body movements.
Okay. So from a normal person perspective, how can they recognize a seizure in someone else? Can they?
Majority of the time, if it is a convulsive, it is a very easiest thing to do. I mean, everybody of us will recognize what convulsion is. But when typically to identify a seizure or a non-convulsive seizure is these patients lose track of the surroundings. In that brief episode, even if you touch them, talk to them, they are not receptive or they are not responsive. And then it depends upon the degree of loss to your surrounding. So it's kind of a spectrum. You can fit anywhere from just a stare to involuntary thrashing movements, and everything is called a seizure.
Okay, and how long does it work?
Normally, whenever the seizure happens, it generally stops within 1 to 2 minutes. But then there are few
1 to 2
minutes. Yeah,
it's still a lot. Like for a person who does not know of the surrounding.
Yeah, it is quite a dramatic experience to have a seizure in front of everybody, and that is the reason we have a lot of stigma associated with epilepsy in our society.
Okay, and so someone recognize an epilepsy, actually a seizure, because the person who is talking to does not recognize the surroundings and might have involuntary movements.
Right.
So if this happens, what is the next thing to do?
So so basically we are trying to see whenever this symptom is reported to a physician, generally a clinician diagnoses epilepsy on the basis of clinical history, thorough clinical history, and an EEG, which confirms the diagnosis of seizure or epilepsy. Okay. But when you, so the first step is to get the diagnosis of epilepsy right.
So to go to the physician.
And once you get the diagnosis of epilepsy, normally based on the EEG findings and your clinical history, the clinician will start you on some medicine.
Okay.
So that's how it goes.
Okay. But actually a step back. When does seizures or epilepsy actually start appearing, and like what is the actual normal age for appearance for this disease?
Okay, so there is no normal age of the epilepsy. Epilepsy can occur from day one or a childhood. From day one of your life till you are alive. So there is no, but maximum of epilepsies, they start in the early childhood, I would say. And that depends on the cause of epilepsy. So what causes that epilepsy? So if you ask me now, epilepsies can be briefly classified for a common people as a simple epilepsies or a complex epilepsies.
Okay.
It's kind of, so simple epilepsies, this is not a medical classification for in general to understand. So simple epilepsies are a self-limiting epilepsies or a benign epilepsies, or they come and they go on its own.
All right.
So when the clinician look at the EEG findings and the clinical history and establish a diagnosis of this simple epilepsy, they will just put you on one medicine. And most of the time this epilepsy will go down, and over a period of growth years, these epilepsies die down.
Oh, okay.
So they are kind of a self-limiting epilepsy.
Okay. All right.
So those are what we call them as a simple epilepsies. They do not really affect your cognition or growth or any other things. They're just the simple epilepsies. They come and they go on their own. While they are active, you have to treat them with medicine.
All right.
So that is one part of epilepsy. Now the second part of epilepsy is a complex epilepsy. So complex epilepsies generally have some cause in the brain. So when they come, when they start, suppose you get an epilepsy, and when you're diagnosed epilepsy with a clinician, he put you on one drug.
Yeah.
So the complex epilepsy will go down immediately and again come back.
Okay, so they are drug resistance.
Not really at this point of time, but yes. So they will again come back. Now here at this point of time, physician would try to change the medicine or put another medicine to it or supplement with another medicine. If that happens, then the seizures will go down and it again surface back. So, and this pattern keeps on continuing.
And is it worsening or getting?
So kind of you keep getting those seizures despite you being on a lot of medicines. So the fundamental thing here is most of these patients will have some or the other cause associated with it.
Okay.
Like
example?
The structural malformation of the brain, some infections around it, some vascular malformations, some tumors. If you have a scar for some reason.
A scar?
Scar. If you have a scar for some reason. And there are few epilepsies which are genetic in nature.
Okay.
So these are kind of the causes of epilepsies that, whenever these kind of causes produce these epilepsies, they are generally complex epilepsies.
All right.
In simple epilepsy, there is generally a MRI brain is normal. Your EEG features are very classical of simple epilepsies. They are different so EEG signatures of epilepsy.
We're getting on how to actually recognize the different types of epilepsy.
Right. So basically, we are trying to for a general people, you have to identify the pattern of those epilepsies. So if you have see what happens in our as majority of the epilepsies are simple epilepsies.
Okay.
So what happens whenever if a patient comes to me with the first or two seizures and then I put on a medicine, by general tendencies, I try to tell them that look, with age, this epilepsy is going to disappear.
With age?
With aging.
Oh, with years?
With years, months? Years to pass on. This epilepsy is going to go down and will end.
Okay.
As 70% of the epilepsies, close to 70 I would say,
are simple.
Epilepsy. That's why majority of the physicians, they have a tendency to tell their patients that this epilepsy is going to go with the treatment within few years within next 3, 4, 5 years depending on the severity.
Okay.
And that is why there is a common understanding that all epilepsies go away in 4 to 5 years, which is not the case. So if you are encountering or if you are having a complex epilepsy, or normally we call it a drug resistance, because you are putting on drugs, keep adding drugs, and it's not working. So that is not the simple epilepsies which is going to go down over a period of time. So this recognition of pattern is must, and I think any parent should understand these patterns to say that probably we are heading towards a complex epilepsy. And if you label a complex epilepsy as a simple epilepsy, or if you misunderstood the complex pattern as a simple, then you are going to lose many years trying to take treatment without finding a cause for the complex epilepsy.
And the epilepsy is getting worse.
Epilepsy is getting worse. There are a lot of things around it. We are going to we will come to that later on.
Yeah.
But yes, so that is how it is very essential to understand the patterns of this epilepsy and differentiate between simple epilepsy and a complex epilepsy. Or I normally, I think even I keep on requesting our physicians, put this word on the paper. It's a bad epilepsy or a complex epilepsy or a drug. Generally, we have a tendency to label just epilepsy disorder. I think we should start labeling them as a simple epilepsy versus complex epilepsy, or a drug resistant epilepsy in our medical terms, of course.
All right. How many drug resistant epilepsy do you personally see every week?
So I mean, we work in a collaborative setup or a department. So roughly we see around 20-25 complex epilepsies. This being a tertiary referral center, we generally see complex epilepsies only.
Okay.
So because I mean, it may not really reflect the percentage.
Yeah, but just to have an idea of how common this can be.
So if you want to understand the population dynamics, so what they say that there is a prevalence of 1% of population.
1%?
So epilepsy exists in 1% of the population.
Indian population or worldwide population?
Worldwide.
Okay.
It's a 1%. But I mean, even if you take little lower estimate, I would say 0.5% is the realistic estimate.
So one every 200 people.
Yes, one for 200 people. Yeah. And then 30% of them are drug resistant epilepsy, truly drug resistant or complex epilepsies. 70% of them are simple. Either they are very well controlled on the drugs, or they die off and they just disappear over a period of time. So that's called simple or drug resistant. So simple epilepsies or benign epilepsy syndromes.
Okay, benign. Yeah.
Right. So that is so now if you want to understand the dynamics for the city of Pune, where we are sitting, right?
Example, yeah, sure.
So yeah, Pune has a population of 1 crore. 1 crore is like
10 million people.
10 million people.
10 million people, right.
So for 1 crore, how much is 0.5%? 50,000 people. 50,000 people are suffering with epilepsy.
Okay.
Of which 30% is like 15,000 patients are complex or drug resistant epilepsy. Okay. So total of 15,000 patients are there residing in only Pune district.
Okay.
For a drug resistant or complex epilepsies.
Nice.
So it's a lot of patients.
Right, lot of people.
Lot of people.
Okay, so I think we've kind of had all the basic questions regarding epilepsy and how to find it, how easy it is to find other people with epilepsy. So, do you want to move into a more clinical perspective part?
Yeah, sure, please. Yes.
Okay. So, now that we understand that there is an epilepsy patient, either simple or drug resistant. Actually, I've been here for these 2 weeks, and I see that you check MRIs, PET scans, and EEG both together.
Yeah.
So do you do this as well for the simple epilepsy, or with the simple you just use EEG?
Yeah. So again, as I said, this is a tertiary referral centers, and we don't really see simple epilepsies.
Correct. Sorry.
But yes, for a simple epilepsy, we really don't need to do anything. With a clinical history and a EEG, if you put the patient on a right kind of treatment, right dose, right kind of the drug, and the person is taking it in a right manner,
Yeah.
then most of the time your epilepsy is controlled.
Alright. And you don't need any MRI or PET.
You don't need any MRI, PET, EEGs frequently. If you are clinically controlled, that means on one drug you do not have any breakthrough seizures or any seizures for 2 years, 3 years, 4 years. Then we understand that probably we are looking at a simple epilepsy, and we just discontinue the drug gradually over a period of time.
Oh, it gets discontinued after some time.
After some time, we just discontinue the drug, and then you are on. You're cured of epilepsy, kind of. You're free of epilepsy.
Nice.
Now, but what happens when the epilepsy is complex, or what we call typically a drug-resistant epilepsy? Then we understand that there has to be some cause. Either we can find it out, or we cannot find it out is a different story.
Right.
But there has to be a cause. Now, and that's why we need to find it out. Because otherwise they're not going to be controlled by the drugs, medicines.
We have to remove the cause in order for the epilepsy to stop.
So now here the idea is, sorry, I was trying to say something. So whenever the drug resistance is established, like whenever we label that it is a drug resistant epilepsy, or the pattern is looking like a drug resistant epilepsy, it means that we need to evaluate it thoroughly, and only those complex or drug resistant epilepsy needs thorough evaluation. What you are seeing here.
All right.